So we have mentioned prophylaxis in children. We know that this is a golden standard for the treatment. We mentioned that the prophylaxis might be of significant benefit for some or certain groups of adults, especially for those who bleed frequently. But prophylaxis, as well as any other treatment we provide our patients with, might be complicated by certain difficulties and or barriers. So what are they? What are these difficulties and barriers of prophylaxis? Perhaps risk of transmission of pathogens, or perhaps problems with central venous lines, like infection, thrombosis, perhaps allergic reactions or inhibitors, problems with compliance or impact on patients' lifestyle. Certainly it's true that these barriers are there, and different patients and different caregivers are finding their own ways how to overcome them. But the good news is, and I'm deeply convinced that they, in vast majority of cases, can be avoided or overcome. So we can continue step by step. So let's start with venous access. Venous access might be the barrier for prophylaxis, mainly in children younger than 2 years. These small kids, toddlers, are very difficult to inject, and the venous access might be a significant limitation for providing them with prophylaxis. That was the reason by especially in past, to facilitate early start of prophylaxis, central venous lines were often used in children up to 6 years of age. However, there is certain risk of infection, and there is also the risk of thrombosis, even in patients with haemophilia, and it's very likely that this risk was in past underestimated. To avoid those risks, it is possible to start prophylaxis gradually, like, for example, in the Canadian regimen mentioned before, or in the new German regimen. So this is the way how to avoid necessity for insertion of central venous lines in young children, to start the prophylaxis gradually, not very frequently, low doses, low frequency, which very often can be given through the peripheral vein. And in vast majority of patients, we are able to avoid the insertion of central venous lines. It is also the part of the patient-tailored strategy or the patient-tailored approach. On the other hand, it's fair to say that central venous lines will always be unavoidable in certain patients, like patients on immune tolerance therapy and so on. But we are able to decrease the number of patients who need central venous lines significantly. Transmission of pathogens. Currently, plasma-derived and recombinant concentrates are recommended for use in prophylaxis in children. Plasma-derived concentrates are very safe. However, there are certain published data saying that despite of that very high safety profile, the pharmacovigilance is still imperative. From that point of view, from the infectious disease point of view, the recombinant concentrates are currently the safest available alternative, and their use should be encouraged in children. The reason is very simple. We can protect, or we can test for the diseases we know, but there potentially might be diseases we don't know so far, and at least for me, it's really imperative that the HIV tragedy should never happen again. Allergic reactions. It's fair to say that allergic reactions might be quite severe. They might lead to withdrawal of the particular concentrate. Fortunately, they are relatively rare. Inhibitors At the age, or currently at the time when we have solved the problems with the joint damage, mainly through the prophylaxis and through the proper treatment, the primary concern of the hemophilia treatment nowadays are inhibitors. They are influenced by different factors, genetic ones, which are obviously difficult to avoid, and by individual and or treatment related, and those are often avoidable. There are many different recommendations what to do, or better to say what not to do, to decrease the risk of inhibitor development, especially in young children and the very beginning of their therapy. In general, we can say that we should do everything to avoid the danger signals, the danger signals which are increasing the risk of inhibitor development, which are so. On the slide, you can see, for example, that it's not recommended to give the factor VIII concentrates during the surgery, during the infection, or during the vaccination. So during the time when the body is alerted, when there is increased immunological response or the stress response, and if you give the concentrate at that time when the body is under stress, you can increase the risk of inhibitor development. But to talk about this in details, it's definitely beyond the scope of this talk. It has not been proven that the use of plasma-derived von Willebrand factor-containing concentrates would decrease the risk of inhibitor development. What, on the other hand, was shown by on the canal study cohort was that the risk of inhibitor development during prophylaxis is 60% lower compared to on-demand treatment. In other words, if you give the child a prophylactic treatment, you not only help him or her to prevent the locomotory apparatus, to prevent the joint bleeds, but you also decrease the risk of inhibitor development significantly. Some of the regimens, like those I've mentioned before, are particularly focusing on that issue and trying to find out what is behind. So, what could be the summary? What could be the conclusion of this talk based on current knowledge? We can say that there is evidence that prophylaxis in children with hemophilia significantly decreases the damage of their joints and thus increases the quality of life. This treatment is cost-effective in long-term perspective and is decreasing the risk of inhibitor development. It has been also shown that prophylaxis is beneficial in adults who bleed frequently. It's decreasing the number of joint bleeds, it's decreasing the pain, and it does not have significant overall impact on health economics. On the other hand, the chosen regimen, the dose and the frequency, will always be the decision of the treating physician and the patient, bearing in mind to minimize potential risks, including inhibitor development, bearing in mind the concentrates availability, which might be different in different countries, bearing in mind the resources provided. But we also should stress that the direct costs of the factor concentrates are often counterbalanced by decreasing long-term expenses, including less orthopedic complications. And even indirect costs are counterbalanced by improvements in working life duration, reduction in time off work, off school, and so on. When talking about the prophylaxis in adult patients, we should say that the way to identify patients who will benefit from extending the prophylaxis from childhood to adult age is still not clear. At the last slide of this talk, I would like to show you two pictures from the haemophilia summer camp in my country. 25 years ago, the picture would be completely different. But thanks to prophylaxis, you currently will never you will never be able to say who of those kids are healthy and who are hemophiliacs. They both have similar quality of life. They both are able to do whatever they want, and this is thanks to prophylaxis. Thank you for your attention.